case discussion on phyllodes tumors of breast. Dr. Omkar Nath, who is a third-year DNB resident at Tumor Mangur Hospital, will present the case. And Professor Shomita Chatterjee, who is Professor of Surgery at IPGM SK Hospital, will moderate the session. So, Omkar, you can share your screen and present. I think you can present the whole case, including the history and the examination, and then we discuss at the end.
Good morning, sir and ma'am. I am Dr. Omkar Nath, DNB PGT third year from MR Mangur Hospital. I am going to present a case on phyllodes tumor. A 38-year-old female housewife by a patient from Kolkata came with the chief complaints of lump in the left breast since 6 months. History of presenting illness. Patient was apparently asymptomatic 6 months back when she noticed a lump in the left breast while taking bath, which was initially of approximately 2 into 2 centimeter in size, insidious in onset, gradually increasing in size, but from last 2 months it grows rapidly to attain the present size. It is not associated with pain or nipple discharge. No skin change, no history of trauma to the breast, no history of swelling elsewhere in the body. There is no history of loss of appetite or loss of weight, no history of taking OCP or hormone replacement therapy, no history of irradiation, no history of back pain, no history of jaundice, vomiting, or ascites, no history of cough, hemoptysis, breathlessness, or chest pain, no history of headache, vomiting, blurring of vision, or weakness of limbs. Personal history. Patient is taking mixed diet, has normal bowel and bladder habits, and there is no any known addiction. Past history. Past history. There is no history of any chronic illness like diabetes, hypertension, bronchial asthma, or TB. No history of any surgery in the past. No history of similar illness in the past. Menstrual history. Patient attained menarche at the age of 14 years, has a regular cycle of 3 to 4 days with adequate flow. Obstetric history. She is P2L2A0. She has 2 children, both full term, has a normal vaginal delivery. Age at the first childbirth was 21 years, and breastfeeding was given up to 1 year for both the children. Family history. There is no history of similar illness in any family member. There is no history of breast and related cancer running in the family. Summary. There is no any significant treatment history. Summary. A 38-year-old premenopausal woman came with the complaints of painless lump in the left breast since 6 months duration, initially of 2 into 2 centimeter in size, gradually increasing, but from last 2 months, it increases rapidly to attain the current size. There is no pain or nipple discharge or any ulcer associated with it. There is no any systemic symptoms with no significant family history.
Sir,
I think we can discuss. Yes.
Pardon?
Yeah.
So shall we take some questions on the history?
Yes.
Omkar, can you move back to the first slide, please, as we move through the slides? Yeah. So you said that the patient was apparently well 6 months back, and then over last it was initially smaller and then has gradually grown over the last 2 months. And you've said there is no associated pain or nipple discharge. Now, if there is no associated pain, what are your thoughts about this mass? 6 months mass, 2 months rapid growth, no pain.
Sir, it could be the could be due to phyllodes tumor or breast carcinoma.
Now, if see here, you know you're presenting a case of phyllodes, but if you have a breast lump which is painless, would your first diagnosis be a phyllodes if you have not seen the patient, or should it be a suspicion of malignancy?
Suspicion of malignancy.
Exactly. That is so. Don't be biased. Don't immediately say it could be phyllodes. It could be a breast neoplasm. and more probably malignant because pain is usually associated with benign disease. Okay, but remember, we'll come back to this pain and nipple discharge once again later once we have seen your clinical presentation. Okay, can we move to the next slide, please? Okay, you've asked for no history of fever. What are you trying to rule out?
I'm trying to rule out, ma'am, if there is chronic breast abscess, ma'am, that could also present like lump.
Right.
Fever.
But if it is a chronic breast abscess, will there be fever? Fever is usually a feature of an acute breast abscess. Okay, so again, that is why I wanted to say, if there is a chronic breast abscess, there is unlikely to be history of fever. Okay. The next point, you've said that there is no history of trauma. What are you trying to rule out again?
Trauma, there could be a hematoma or there could be the traumatic fat necrosis, which could present
so
like
this.
this.
It is an acute history again, usually. Okay. Yes, you can have traumatic fat necrosis progressing over time, but then it is usually an acute history. A 6 months history is unlikely. Third, you've talked about loss of weight and loss of appetite. Is loss of weight and loss of appetite commonly associated with breast malignancy?
Yes.
No, it is not. Okay. So though loss of weight and loss of appetite is commonly associated with a lot of malignancies, breast malignancy is usually not associated with loss of weight and loss of appetite. So don't try to fit into a malignant pictures. Okay. So the rest of it you have given the possible metastatic histories. Can you move to your next slide, please? Next one. Okay. So chronic illnesses like diabetic hypertension, bronchial asthma, tuberculosis, is it only for the purpose of preparing your patient for further management, or can these have a relation with the breast lump?
There's no any relation, ma'am, just for the sake of completing history, ma'am.
See, the point is there is a relation which you have to keep in mind. I agree it is mostly for completion of your history and workup, but there is an entity called diabetic mastopathy, which also presents with a lump, which is often mixed up with granulomatous mastitis. Okay. Also,
and chronic tubercular lesion in the breast.
Yes. Okay. Again, with tuberculosis, there is a possibility that it may be again a granulomatous mastitis of tuberculous origin. So it is not entirely for completion, though most of the time it is for completion, but these thoughts have to be at the back of your mind that if she is a diabetic, if she does have a history of tuberculosis, am I dealing with a breast lump which is related to her chronic comorbidities? Okay, that is to be kept in mind. Can I move to the next slide, please? Yeah. So age of menarche and cycles, that is okay. The family member slides, if you can please come up with it. The next slide, family members, family history rather. Okay. So you have written no similar history in family member. In a breast case, from a postgraduate, what we expect is no similar history in first or second degree female relatives in the family. Okay, so that is what we want to hear. And also there are some malignancies which are BRCA linked, which may be present even in the other male members also, like a CA colon or a CA prostate, which may also be genetically linked. So you can say no other history of other malignancies in the family member. Okay. That also, because not necessary that always a mother has to have a CA breast. You can have a father with a history of a CA colon or a CA prostate, which are also sometimes BRCA linked. Okay. Okay. Can we move to the clinical examination, please?
General examination. Patient was examined in a well-lit room with a female attendant. Patient is conscious, cooperative, and well-oriented to time, place, and person. Well-nourished, with BMI of 22, with Karnofsky performance score of 90. And there is no pallor, icterus, cyanosis, clubbing, pedal edema, or generalized lymphadenopathy. Blood pressure is 126 by 80 millimeter of mercury over right arm in supine position. Pulse rate is 80 per minute. Respiratory rate is 18 per minute. Coming to the examination of the breast, patient was exposed from neck to waist and examined in presence of female attendant. For examination of the left breast, on inspection, patient was inspected in sitting position with arm by side, raising arm above the head, bending forward. and in recumbent position, head above 45 degree.
And one more, leaning forward. 5 positions in all.
Yes, leaning
Right?
forward.
Breast has to be examined, 5 position. Sitting with arms by the side, raising head above the head, bending forward, hands on the hips, and in a reclining at a 45 degree angulation. So 5 positions. Okay.
Sitting position with arm by the side. There is gross enlargement of the left breast with asymmetry noted and is slightly lower than the right breast and was displaced outwards. There is fullness noted in the left breast with bossulated surface and well-defined margin. Skin over the swelling appears stretched and shiny. There is presence of dilated veins. There is no ulceration, dimpling, puckering, or body orange. Nipple and areola complex appears enlarged and flat. There is no nipple retraction or any nipple discharge. No fissure or ulcer over the skin or nipple. There is no axillary or supraclavicular fullness noted. With arm raised above the head, lump becomes more prominent. No puckering, dimpling, body orange appearance. With leaning forward, left breast falling forward more than the right breast. Hands over the hip and contracting, lump becomes more prominent. Palpation. There is no warmth, non-tender, single lump palpable of 14 to 10 centimeter in size, involving all quadrants of the breast, with well-defined margin, firm to hard in consistency, with bossulated surface, with it mobile. And the lump moves along with the breast. The lump is not fixed to the skin or underlying chest wall. Nipple and areola come to be normal in clavicular lymph node palpable. On systemic examination, abdominal examination, abdomen is soft, non-tender, not distended, no organomegaly noted, no mass palpable. On cardiovascular examination, S1, S2 heard. Respiratory examination, bilateral air entry is present, no added sound. On CNS examination, no neurological, no focal neurological deficiency noted.
Oh, why do you abbreviate like this? You can just mention the sentence.
And
Okay.
then he forgets what the abbreviation is. Yes.
Okay, finish up.
Summary. A 38-year-old premenopausal woman came with the complaints of painless lump in the left breast since 6 months duration, initially of 2 into 2 centimeter in size, gradually progressing, but from last 2 months, it increases rapidly to a 10 current size. There is no pain or nipple discharge associated with it. There is no any systemic symptoms with no significant family history. On examination, general examination is normal. On local examination, a well-defined lump in the left breast with shiny skin and dilated veins over it. Lump is firm to hard, non-tender, mobile with bossulated surface, measuring 14 into 10 centimeter, involving all quadrants, with no skin or chest wall involvement, and no axillary or cervical lymphadenopathy.
Okay, so your provisional diagnosis is?
A 38-year-old lady with mobile lump involving all quadrants of the left breast is most likely a case of phyllodes tumor.
Okay, so we've already discussed the history. What I want to know is that you think it is a phyllodes tumor. What are the points in favor in history and that in clinical examination, which will tell you that we suggest that it is probably a phyllodes tumor?
First, starting with the age, phyllodes is most common in 35 to 45 years of age, and lump is rapidly increasing in size, and on examination, there is shiny and stressed skins with dilated veins over it, with bossulated surface, and not fixed to the underlying skin or underlying muscles.
Okay.
And there is no lymphadenopathy.
Yeah.
So the good thing is, see, you talked about age, that 35 to 40. Yes, phyllodes is common in 35 to 40, but that does not mean that every lady within the age group of 35 to 40 with a breast lump will be a phyllodes. So the age fits into phyllodes, but you can very well have a invasive ductal carcinoma also. As far as clinical, you're right, the huge size, shiny skin, dilated veins, bosselated surface. You had mentioned a point that the nipple is displaced outwards. That is a very characteristic feature. If you have such a large malignancy of the breast, usually the nipple gets pulled towards the lump. And in phyllodes, typically the nipple gets pushed away from the lump. So that displace outwards is a good lead. Also, non-fixity to skin and non-fixity to the underlying chest wall. Though it is such a large size, there are no axillary lymphadenopathy. So all these features make it suspicious to be a phyllodes tumor. Agreed. So how would you like to proceed? How would you like to confirm your diagnosis?
I will first go for ultrasound.
Omkar, before you proceed, what do you think? Is a benign phyllodes tumor or is a either borderline or malignant phyllodes? What's your impression? Because phyllodes tumor also clinically can be grouped into these.
Yes. So it could be, sir, according to the size of the lump, it could be, sir, borderline phyllodes tumor.
Why do you say so?
So size
is more of a histological criteria than a clinical criteria. Try to understand. Either you say it's a benign or possibly
benign. Then benign.
It's a benign.
Yes.
Such large lump, rapidly growing over 2 months. Still, you believe that it might be benign only?
See, the duration history is very short. There is rapid progression during these 6 months of period. You sometimes get phyllodes who come back to you after months. Okay, so this rapid progression over a short period is more hinting towards a malignant phyllodes. But yes, the final diagnosis will definitely be after a histopathological assessment of the lump. Okay, but yes,
clinically, you cannot say borderline. Borderline is difficult to say clinically.
Borderline you cannot comment clinically. It is totally a history. We will come to that discussion as to when we will call it a borderline. Okay, so how would you like to proceed with this patient? How would you like to work this patient up? Where's Omkar?
Omkar, you're lost?
Got logged out.
Okay. No, Milind is there.
He's coming back. He's there. Yes, Omkar. Omkar, can you switch on your audio, please?
Yes. Sorry, ma'am, it was disconnected, ma'am.
I am.
Okay, no problem.
So, can you hear me?
Yes, ma'am.
Okay, fine. So, can you tell me how would you like to proceed with this patient?
Ma'am, I will go for imaging ultrasonography of the breast with bilateral.
After the term, I will go for triple assessment. Clinical examination is done, and then this is the usual answer in a breast patient.
I will go for
the phyllodes, be it a malignancy, the approach is going to remain the same. So you have completed your clinical examination. What are the other two components of triple assessment that you are going to follow?
Imaging and tissue diagnosis.
Imaging and tissue diagnosis. Fair enough. So what imaging would you like to do in her case?
Ultrasonography of bilateral breast with axilla.
Okay. Ultrasonography of bilateral breast and axilla. So what classically do you find during ultrasonography of these patients?
There will be on ultrasonography. I will see the echogenicity of the lump.
So what sort of echogenicity are you looking at? It is more of a homogeneous structure that you see on the well-defined homogeneous structure in the ultrasonography with absence of what? Which are the clinical classical USG findings or mammo findings that you see in malignancy which you do not see in case of phyllodes?
Is it all solid or there are some cystic spaces in between?
There will be some cystic spaces along with the solid areas in case we will see in case of phyllodes tumor. Okay. And in case of and in case of malignancy, a tumor will be more wider than taller.
No.
Malignancy reverse.
It is a reverse. It's a reverse.
Yes,
taller than wider.
Yeah. And
what about margin?
and there will be heterogeneous echogenicity in case of heterogeneous echogenicity in case.
How do you comment about margin in a phyllodes?
Your audio is off. Omkar, your audio.
Yes. In case of phyllodes tumor, margin will be regular with well-defined margins, and
how it is described? How it is described classically? Benign, borderline, and malignant phyllodes have a different
Yes.
pattern in the periphery. Benign is described as it's a pushing margin. It is just pushing the rest of the breast tissue. In malignant, there will be
infiltrating.
yes.
Okay, two different words. One is pushing or abutting, the other is infiltrating. And as sir has already said, that in borderline, that is mainly during or after a tissue diagnosis that you can comment on borderline.
Or in borderline, you have a focal infiltration. Okay. He must be knowing all the important points.
Of speculations or calcifications which we see in malignancy, these are usually absent in case of a phyllodes. Okay. What about tissue diagnosis? What tissue diagnosis would you like to do?
I will go for a true cut biopsy.
You would like to go for a true cut biopsy.
Yes.
And in a true cut biopsy, what is the classical picture that you get?
There will be cystic spaces. There will be cleft like spaces is present between the tumor cells.
So
what is the basic histology? What is the basic histology in phyllodes? Is it duct, lobule, or something else?
Sir, it's ductal along with the stromal.
It's not ductal. It does not arise from the duct or the lobules. It arises from the connective tissue or the stroma of the breast.
Stroma.
Okay. So it is more of a fibroepithelial neoplasm arising from the connective tissue or the stroma of the breast. Duct and lobules will give you ductal carcinoma or lobular carcinoma, as the case may be. Okay. So usually they say that there is a biphasic proliferation. You have some proliferation of mammary epithelium and you have proliferation of connective tissue or stroma, as we have said. So there is a biphasic proliferation and it is a fibroepithelial neoplasm. That is a typical. We use the word phyllodes. This is where the word phyllodes comes from. What does the word phyllodes mean?
Phyllodes means leaf-like
structure. Correct. So leaf-like, it's not the gross structure. It is the histopathological image which gives you that leaf-like image, which we call the leaf-like structure. Okay. So if you have got, you said that there are cystic spaces. What leads to these cystic spaces? It is basically a solid tumor. But why do you have these cystic spaces?
If there will be the pressure necrosis, hemorrhage and necrosis in between the.
So it is hemorrhage and necrosis and degenerative changes within the tumor which leads to these cystic spaces. In your clinical examination, you said that there was no involvement of the skin or the nipple areola and there was no fixity to the chest wall. Is this classical of phyllodes or is this only present in the patient that you examined?
Classical of phyllodes.
Oh, so what happens classically? What is the pattern of progression of the disease?
When the tumor starts, what happens to the tumor growth and its extension to the periphery?
So it is a rapidly enlarging tumor, number one. So because it is a rapidly enlarging tumor, the skin gets stretched along with it.
Yes.
That gives you that shiny skin that you're talking about, and the veins get prominent and dilated. So as it rapidly enlarges, there is hemorrhage and necrosis within it, giving rise to the cystic spaces. But there is no involvement. There is no involvement of the skin. There is no infiltration into the skin. So previously in the older episodes of Bailey and Love, they said you could put a needle in the subcutaneous plane and you could move the needle. We don't do it anymore, but that was classically described as how you are going to diagnose a phyllodes. So the skin gets stretched, leading to pressure atrophy and necrosis of the skin. but there is no infiltration of the skin per se. And again, when there is rapidly growth posteriorly also, there is no infiltration into the chest wall. So that is why you very correctly said that the mass was mobile over the chest wall. So rapidly enlargement, skin stretched, there may be pressure atrophy, but no skin involvement as such. That is, there is no puckering, no dimpling or all that. Difficult to pinch the skin up because of the large size, but the skin apparently up front is free. NAC is free and chest wall is also free. This is a typical characteristic which the way the tumor grows, that describes what you find clinically. Okay, you also get that bossylated appearance, what you have said, that is because of the cystic changes inside. There are areas which are cystic, the areas which are solid, which gives you the variegated consistency and a bossylated appearance. Okay, I think he's got disconnected again. Shankar, are you there? Oh yeah, he's back again.
Yes.
Okay, so you said there were no axillary lymph nodes palpable. Why is it that with such a huge lump, no axillary lymph nodes were palpable?
In case of phyllodes, there is no metastasis seen usually.
There is no metastasis at all, or
in malignant phyllodes, there will be mostly hematogenous spread.
So there is no lymphatic metastasis, but usually it is hematogenous in spread if it is a malignant phylloid. So if there is a hematogenous spread, where do you suspect the metastasis to be? What is the commonest site of metastasis in a malignant phyllodes?
Lung.
Yes, lung. So it is the usual places of metastasis is lung, liver, brain, bone. But in case of phyllodes, the lung is the commonest. Yes, you can have metastasis elsewhere also, but the lung, you're correct, is the commonest area of metastasis. But do you not get any lymph nodes with such huge lumps? Sometimes, in reality, when we examine a patient, some lymph nodes may be present in the axilla. So what are they due to?
If you palpate few lymph nodes in the axilla, how do you explain? Metastatic or any other way that some lymph nodes enlarged? Often you get the report.
So reactive.
There could
be some reactive lymph nodes also. But just to complete the discussion on this, you have to remember that there are some variants where a lymphatic spread may be present. They are not true phyllodes. They are some of these sarcomas of the breast which look clinically like a phyllodes, where you might have an axillary lymph node present. They might have lymphatic spread. Some sarcomas of the breast like a rhabdomyosarcoma, a synovial sarcoma. So these diagnoses you will never get clinically. This is only a histopathological. So if you do get a case which clinically looks like a phylloid, but there is an axillary node, you must first say that it is not a common route of metastasis. The common is hematogenous. We might get some reactive lymph nodes, but they are usually not metastatic. And then if you've answered well and you moved on and they ask you that, can you have a metastatic node in certain tumors looking like phyllodes? Yes, certain breast sarcomas have lymphatic spread, which could be a rhabdomyo or a synovial sarcoma or a fibrous histiocytoma. These are the common few variants which may be there. But upfront, it should be a hematogenous spread, and if there is a node, it is a reactive node. Okay? Fine. Now, moving on, you have diagnosed, you've done...
any role for ISC?
Yes.
ISC.
Okay. Yes, sir.
ISC role?
If you say with the diagnosis of phyllodes, do you like to have any ISC being studied in this?
Sir, if diagnosis of phyllodes, if a histopathological diagnosis of phyllodes is confirmed, then no needs of ISC.
Yes, but still some ISC is done. Any role
what
for
are the common ISCs that you are aware of?
ERPR status.
ERPR, HER2/neu. These are
HER2/neu and
Ki66. But are they positive or present in a phyllodes?
No.
They are not. But yes, as Sir said, there are certain immunohistochemistry markers which may be present like a P53, Ki67.
P53
So these may be evaluated, but the triple one we do, the ERP or HER2/neu, these are not present in a phyllodes. So don't say I will not do it, but there are certain specific markers of which the two commonly available are Ki67 and 53. Then there is an EGFR, then VEGF. There are a lot of other markers which may not be commonly available, but at least you should may mention P53 and Ki67. Okay, so you said that you are going to do a core needle biopsy and get to a diagnosis. Now, a benign phyllodes is commonly confused with another benign breast disease. What is that?
Giant fibroadenoma.
Yes, you have they are histologically very similar, so they are often confused, but yes, your clinical diagnosis will ultimately, the final surgical excision specimen will give you the final answer, but yes, they are commonly mistaken with a fibroadenoma. Similarly, a malignant phyllodes may be mistaken for another breast pathology. Any idea what that is?
Madam has already told you.
Ductal carcinoma in situ.
A minute back.
No. Ductal carcinoma is a different behavior. Behavior like a phyllodes, malignant phyllodes, but it can be something else, not a classical.
Which might give a lymph node but positive in the axilla. We just discussed it.
Rhabdomas.
So it's a breast sarcoma.
That is again a
breast sarcoma.
Soft tissue sarcoma. Soft tissue sarcoma in the breast. That can happen. Okay.
Yes, it could be a sarcoma. There is one malignancy which is similar, which is a metaplastic carcinoma, which is histologically similar to a phyllodes. So remember, a benign may be confused with a fibroadenoma, and a malignant may be confused with a sarcoma, or sometimes a spindle cell metaplastic carcinoma. Okay, fair enough. So your patient had a 14 by 10 centimeter lump, right?
Yes.
With a negative axilla. Skin was...
any role for advanced imaging like MRI or CT?
Sir, in case of phyllodes, if we are suspecting malignant phyllodes, then we can go for CT thorax. If we are suspecting
local imaging, that will come later. Local imaging, do you think is MRI or CT will be required in this patient?
No,
or in what circumstances you'll do? But sometimes you need to do a advanced imaging. When? If the tumor is infiltrating the chest wall.
If we are suspecting chest wall fixity, then we can go for MRI.
Yes, what is the extent of involvement in the chest wall? Otherwise, if the tumor is mobile, MRI is not mandatory.
Yes.
See, what we said is that classically it does not infiltrate into the chest wall. That is a classical description. But as sir said, you have cases. We had a patient who had not only fixity to the chest wall, it had infiltrated into the ribs as well. So we had to do a thoracic excision with our plastic colleagues, created a flap on it. So there are situations where the rule is twisted. So classically, they don't involve skin and chest wall, but very large tumors might. And that is when the role of an advanced imaging. Don't be indiscriminate and ask for an MR or something for routinely for all patients. But these are the patients where it may be required to see. Clinically, if you're feeling that, yes, it seems fixed and all, yes, you're justified in doing an MR or a CT to see the extent of infiltration into the chest wall. Okay. Now, you have a patient who has a 14 into 10, you said. Okay. So what will be your plan of management for this patient?
I will go for wide local excision.
How is the breast? Is it a bulky breast, or is it a breast which is not bulky and tumor is almost on the whole of the breast parenchyma?
Bulky breast.
Bulky breast. Okay. So if it is okay, let's keep the 14 into 10 constant and say that, as sir said, that it is a very bulky breast with a 14 into 10. Then what will be your plan of management?
Then I will go for wide local excision with 1 centimeter margin.
Now, with a 14 into 10, you might need some oncoplastic procedure, because even though it is a bulky breast, 14 into 10 is large. So you might need some oncoplastic procedure to reconstruct the breast. Okay. Now, if it is a smaller breast with a 14 into 10, then what would you do?
Then I will go for mastectomy.
What mastectomy?
Simple mastectomy.
Simple mastectomy. Okay. So no role of an MR in here?
Reconstruction?
No role of an MRM here?
No, ma'am. As there is no lymph node involvement in phyllodes tumor, so
Right.
no
So
need of
routine axillary dissection is not required in case of a phyllodes. You are going to do a simple mastectomy. Okay. So if you are doing sir was asking something. Sir, you were saying something. Role of a.
Yeah, you have to utter in the same line. Mastectomy is primary reconstruction. That is the standard of care for phyllodes. You have to say
Now,
the same line.
if you have usually the pre-op core needle, they will just tell you that it's a phyllodes tumor. Some very good pathologists might tell you that it is a benign or a malignant. Okay. Now, if you know it is a benign, then what is your plan? And if you know it is a malignant, does the plan change?
this. If phylloid tumor is malignant, then we will go for radical mastectomy.
Radical mastectomy, you don't even do that for a CA breast anymore. So yes, you're right. You do a
Total
local
mastectomy.
excision, but you have to keep a 1 centimeter margin on all sides. The same that we say for CA breast, the same thing that if you do a wide local excision, you have to be cautious that you take out with a 1 centimeter margin. Okay. If you know it is benign, you may take a lesser margin. But yes, but usually we do not encourage an enucleation like we do in a fibroadenoma if you know it preoperatively. Now let's assume that somebody's done an FNA, got a fibroadenoma, it was a large fibroadenoma, they have gone in for an enucleation. And the final histopathology has come out to be a benign phyllodes. Get the situation? You've done an enucleation thinking it to be a fibroadenoma, and then the histopathology has come out to be benign phyllodes. What will be your plan now?
Sir, enucleation, if we will left at such, then there will be a chance of recurrence. So we'll go for wide 1 centimeter margin excision of the lump.
You are talking about recurrence. What is the percentage of recurrence in benign phyllodes?
100%?
9 to 13%. Okay, around 9 to 13%. So yes, there is a chance of local recurrence. But is there any role of observation in this patient? We know it is benign.
Yes, ma'am, we can.
So actually going in for a second surgery is debatable. You can discuss it with the patient. You can keep the patient on observation saying that yes, if it does recur, we know it is benign, so it's not life-threatening. If it does recur, we can go in for a surgery at a later date.
Yes.
Okay. Situation 2, that you have taken out this lesion and they say that it is a borderline. This is where the borderline comes in. It's a borderline malignant phyllodes with focal positivity in certain areas. Okay, then what would you do? So you've removed it. The final histopath has come to be borderline with focal positivity. Then what do you do?
Then I will go for simple mastectomy with
bulky breast.
Again, you have to balance it. See, the decision is based on your histopathology versus the patient's breast. What is the type of breast she has? If there is enough volume, you don't need to do a simple mastectomy.
Even in malignant, you are saying you can conserve the breast, and in borderline, you said I'll do mastectomy. Why? That depends on the tumor size, breast volume. Okay. In borderline, there is a role for doing a re-excision with a 1 centimeter margin.
Right. Borderline, again, see the recurrence rate is higher than benign. This was 9 to 13. This is about 15 to 18, 19%. Here again, this is a matter of discussion. As a postgraduate, we would like to hear that you're going to discuss the options with the patient. Okay. You can say that yes, there is a higher percentage of recurrence. We can either wait and watch, or we can go in and do an excision of the cavity, provided you have marked the cavity. If you have not marked the cavity, then cavity shaving is very difficult in these cases. Okay, so you can go in for an excision, and mastectomy is not definitely a first option. Mastectomy will only be considered if it is, most of the breast has already been excised and all that. So mastectomy will not. Now let's say that you've excised and now it has come out to be malignant phyllodes. Then what do? You thought it was a fibroadenoma, somehow you excised it and now it has come out to be malignant. Then what do?
Malignancy will go for.
Many. Do you review the histology report to see about what pathology has commented?
Yes, sir.
What?
See, if you have done a wide local excision and it is malignant phyllodes, what are the things that you will see? You will see the margins. If there is a clear excision,
Clear margin, then
you don't need to do anything. If there is a positive margin, then in a malignant phyllodes where the recurrence rate may go up to 25% to 30%, that is where a re-excision is necessary. A simple mastectomy will again be only the last resort where you know that there isn't much breast tissue left which can be conserved. But even with a simple mastectomy, you must plan a reconstruction because this is not a disease where you can wash your hands off the patient. So you will say that I will do a re-excision. Only in cases where there isn't much breast tissue to be conserved, I may plan a mastectomy, but that too with some plan for reconstruction of the breast. Okay. Now we are using these three words where it is saying benign, borderline, and malignant phyllodes. Okay. So what is the difference, basic difference between a bit of pathology?
First, mitotic figures, it will be 0 to 4 in 0 to 4 per 10 high power field. In case of benign, in case of borderline, it will be 4 to 9, and in case of malignant, it will be more than 10.
It's not 4, it's 5. So below 5 is benign, 5 to 9 is borderline, and above that, above 10 and above is malignant. Anything else? So this is the mitotic activity. Anything else?
Yes, ma'am. Stromal
WHO classification. Okay, there's the WHO classification. So according to which these three are divided. So anything else? What other factors are considered?
Stromal cellularity, ma'am.
It
will be more marked in case of malignancy. It will be less marked in case of benign.
So mild, moderate, and extensive stromal cellularity. Okay. Number 3. So mitotic activity, stromal cellularity, cellular atypia.
Cellular atypia.
Right? Cellular atypia, what happens?
It will be more marked in case of
again mild, moderate, and marked. Okay. Yes. Number 4.
And yes.
Sir was talking about a pushing border and
yes.
infiltrating border. Remember?
So yes, infiltrating border will be in case of malignant, and pushing border will be in case of benign.
And borderline?
And borderline? Focally infiltrative.
Focal.
So infiltrative at places. So pushing in borderline.
Why this difference is important, Ankar? Why do you need to differentiate between benign, borderline, and malignant phyllodes?
Sir, our plan of management and proceedings will be changed, sir.
Plan of management and the behavior of the tumor will be different based on this criteria. As I said, benign, if you excise the clear margin, there is least chance of recurrence, but still there is a chance of recurrence. And borderline malignant, you need to see that adequate surgery is done for this lesion. Is there any role for radiotherapy in phyllodes tumor?
Yes, sir. If in case of malignant tumor, if we are going for simple after simple mastectomy, we should go for radiotherapy.
In all cases?
Reduce the chance of recurrence.
In all cases? No. If we have done a complete excision, the margins are histologically negative.
Tumor free, in case of tumor free margin, we don't need.
So it's not a routine that you have to irradiate all the patients. Okay. If you have a focal positive margin in large phyllodes, which is malignant, in that case, one option is you go. Dr. Shomita, I asked about the role of radiotherapy in phyllodes. I think Madam has joined, na?
Yes.
Sorry, sir, I got disconnected.
Yeah. I asked him role of radiotherapy in phyllodes. So, Ungar, you answer it again.
Yes.
If there is margin, if margin is free, then there is no
benign,
need of,
no role. Benign, no role.
There is no role of
in borderline complete excision, no role.
No role. In case of malignancy, if there is margin is free, then no rule. If margin is positive, then we should go for radiotherapy.
See, about radiotherapy, whole thing, there is no clear-cut mention in the guidelines, but because there is a high level of local recurrence, it is given after discussion with the patients in case of malignancy. But what about chemotherapy?
No need of chemotherapy.
No need. So there is no role of chemotherapy has been defined, and it is not even there in the NCCN guidelines.
Only
so basically
in
the whole
disease.
outcome.
Yeah, if there is only metastatic disease, metastasis to the distant site, then people are giving chemotherapy, doxorubicin and dacarbazine for this. But for a localized disease,
also
no
you're like a sarcoma then. Basically, you're treating it in lines with a sarcoma and giving chemotherapy. Okay, but the whole treatment protocol of phyllodes tumor is basically based on your surgical excision. That is the definitive there. Clear-cut guidelines on chemotherapy are not there. Radiotherapy is debatable, only advocated in case of malignancies where a margin is positive. And that too, no consensus as such. There is a debate and people have tried it out and seen lesser rate of recurrence. You're looking at a lesser rate of local recurrence if you give radiotherapy to the patient. Okay.
I think we have covered.
I think we've covered most of it. Sir, anything else?
Any risk factor for development of phyllodes tumor? Any risk factors? Define risk factors. Onkar, can you mention some risk factor where you can find development of phyllodes tumor? Onkar, you're still there?
Yes, sir.
Yeah. Any risk factor? Can phyllodes tumor happen in male patient?
Phyllodes tumor. No, sir.
No. Patient with gynecomastia may have phyllodes tumors in the breast in male patient. Okay. Some genetic producing factors like P53 mutation, Leaf-Romani syndrome. Okay. So they are the patient who may have a background of phyllodes tumor. Okay. Okay. I think the approach is important. You see, you should take a good history. Try to exclude distant metastasis in malignant phyllodes if the behavior is like that, and then the usual answer. Okay, I think you have covered the almost whole part. Okay. Anything else, Dr. Shomita?
No, I think that's about all. If anybody has a question, because I got logged out, I put it coming from my phone now. So if anybody any questions in the chat box, no questions in the chat box.
No. Okay. No. Thank you.
Thank you.
Thank you, sir. Thank you, ma'am.
Thank you. Okay.